Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's May 2019 issue. There are 4 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice is an original article entitled Analysis of Vascular Event Risk Following Herpes Zoster from 2007 to 2014 United States Insurance Claims Data. This article is authored by Dr. Brandon Patterson from GlaxoSmithKline, Health Outcomes and Epidemiology, Philadelphia, Pennsylvania, and colleagues from other companies and institutions in the United States. Herpes zoster is a painful, localized vesicular rash with pustules and crusted vesicles, usually localized to a single dermatome. When latent varicella zoster virus reactivates, the virus travels along the axons to the skin and causes herpes zoster. The reactivated virus may travel centrally, causing arterial inflammation, changes that may result in ischemia and aneurysm formation. Herpes zoster-associated vasculopathy may be cranial or extracranial and may lead to transient ischemic attacks and stroke. Studies in recent years have reported an association between herpes zoster and an increased risk for assorted vasculopathies, including stroke, transient ischemic attacks, myocardial infarction, and acute coronary syndromes. Most of these studies were conducted outside the United States. In the United States, data are limited to few studies which report increased likelihood for myocardial infarction and stroke following herpes zoster. In the United States, herpes zoster afflicts approximately 1 million people each year, and its incidence is increasing among adults older than 65 years of age. There is thus a need for large, rigorously conducted studies in the United States that examine the association between herpes zoster and the risk for vascular disease. This study sought to estimate the risk for TIAs, stroke, and myocardial infarction after the first diagnosis of herpes zoster, compared to a matched cohort of patients without herpes zoster, using a large national insurance claims database. The risk was evaluated in periods covering 4 weeks before to 52 weeks after the diagnosis of herpes zoster in adults. This retrospective study with matched cohorts used the MarketScan commercial and Medicare claims database linked to a primary care electronic medical records database. Patients greater than 18 years of age at the time of diagnosis of herpes zoster and 1 year pre- and post-herpes zoster diagnosis continuous insurance enrollment from January 2007 to December 2014 were propensity matched to controls using demographics, risk factors for vascular disease, other comorbid conditions, general health, obesity, and smoking status. Approximately 24,000 patients were matched to 46,000 controls, with a mean age of 56 years and comprising 65% female. During the aggregate period, that is, the 4-week period after the diagnosis of herpes zoster, patients with herpes zoster were significantly more likely to suffer transient ischemic attacks. The incidence rate ratios for all patients and patients between 18 and 49 years were 1.56 and 5.12 respectively. Respective incidence rate ratios for stroke were 1.40 and 8.12. In a sensitivity analysis, incident rate ratios for transient ischemic attacks and stroke were statistically significantly increased regardless of age. The authors conclude that herpes zoster was associated with an increased risk of composite events, transient ischemic attacks, and stroke in adults in the period surrounding the diagnosis. These data are significant for reasons that include the following. First, It suggests that herpes zoster infection may be a risk factor for cerebrovascular disease. Second, it has implications for recommendations regarding vaccination against herpes zoster infection, especially with the expansion of such recommendations to include younger individuals. The first highlight is an original article entitled Optimization Sprints: Improving Clinician Satisfaction and Teamwork by Rapidly Reducing Electronic Health Record Burden. The article is authored by Dr. Amber Sieja and colleagues from the University of Colorado School of Medicine and the Health Medical Group located in Loveland and Aurora, Colorado. Implementation rates for the electronic health record, the EHR, have increased, and so has the clinician EHR burden, the latter described as the computer-based clerical work associated with patient care. Clinician EHR burden is implicated as a major cause of clinician burnout. Burnout is characterized by a loss of enthusiasm, feelings of cynicism, and a low sense of personal accomplishment. In addition to its toll on individuals and their families, physician burnout may negatively affect patient care, productivity, and institutional finances. To ease the clinician EHR burden, organizations aim to improve clinician efficiency in using the EHR by providing tip sheets and offering training sessions. However, it is uncertain the extent to which such approaches increase either clinician efficiency or satisfaction with the EHR. Sieja and colleagues designed, implemented, and assessed a novel intervention, the optimization sprint, an intensive team-based intervention designed to reduce clinician EHR burden in the clinic setting, to alleviate clinician burnout, and to improve clinician satisfaction with the EHR. An 11-member team, including a project manager, a physician informaticist, a nurse informaticist, 4 analysts, and 4 trainers worked in conjunction with clinical leaders to conduct on-site EHR and workflow optimization for 2 weeks. Intervention included clinician and staff EHR training, building specially specific EHR tools, and redesigning teamwork. Agile project management principles were used to prioritize and track optimization requests. Clinicians were surveyed about the EHR burden, satisfaction with the EHR, teamwork, and burnout 60 days before and 2 weeks after sprint. This paper describes the curriculum, pre-sprint planning, survey instruments, daily schedule, and strategies for clinician engagement, and reports the results of sprint in 6 clinics. With the use of the Net Promoter Score, clinician satisfaction with the EHR increased from -15 to +12, with -100 representing the worst and +100 representing the best score. The Net Promoter Score for sprint was +52. Improvements were observed in all of the following perceptions. 1. We provide excellent care with the EHR. 2. Our clinic's use of the EHR has improved. And 3. Time spent charting was more efficiently used. Clinician satisfaction with specific sprint activities was delineated. The percentage of clinicians endorsing burnout was 39% before and 34% after intervention. Response rates to the survey questions were 47% to 61%. The authors conclude that EHR optimization sprint improved teamwork and satisfaction with the EHR, is positively viewed by clinicians, and underscore the importance of key members of the sprint team and effective local clinic leaders in achieving its success. The second highlight is an original article entitled Hypertensive Diseases of Pregnancy, Increased Risk of Readmission with Heart Failure, a National Readmissions Database Study. This article is authored by Dr. Junaid Nizamuddin from the University of Chicago, Illinois, and colleagues from several other institutions in the United States. Heart disease, the leading cause of mortality in women in the United States, is a major cause of maternal morbidity and mortality in pregnancy. Pregnant women with a history of hypertensive disease of pregnancy are at particular risk for cardiovascular disease-related mortality. Hypertensive diseases of pregnancy include gestational hypertension, chronic hypertension, preeclampsia, superimposed preeclampsia, and eclampsia. Hypertensive diseases of pregnancy are the most common complications of pregnancy, affecting approximately 8% of deliveries in the United States. Hypertensive disease of pregnancy adversely affects the heart. For example, up to 23% of patients with early onset preeclampsia have mild to moderate left ventricular diastolic dysfunction, and 20% of parturients with preeclampsia have biventricular dysfunction at term. In some women, subclinical biventricular dysfunction may progress to overt peripartum heart failure. A history of preeclampsia is a risk factor for the development of postpartum cardiomyopathy, the latter occurring in as many as 40% of patients. Approximately 25% of women with preeclampsia have subclinical heart failure 1 year after delivery, and while most women recover, 20% continue to have left ventricular hypertrophy, concentric remodeling, and mild decrease in systolic dysfunction as late as 4 years postpartum. Women with hypertensive disease of pregnancy also have a markedly increased likelihood of developing chronic hypertension in the first postpartum year. Although large epidemiological studies have previously documented the long-term increase in postpartum heart failure in women with hypertensive disease of pregnancy, few large epidemiologic studies have examined the prevalence of new-onset heart failure or postpartum cardiomyopathy requiring readmission in the immediate postpartum period. As maternal mortality from cardiovascular disease is increasing, and hypertensive disease of pregnancy predisposes to myocardial dysfunction, the authors hypothesize that women with hypertensive disease of pregnancy would have increased rates of readmissions related to newly diagnosed heart failure or postpartum cardiomyopathy in the immediate postpartum period. To test this hypothesis, the authors employed the National Readmissions Database and examined 90-day readmission rates in parturients with a diagnosis of hypertensive disease of pregnancy who were discharged after delivery. The data revealed that women with hypertensive disease of pregnancy were much more likely to be readmitted with heart failure at rates 2 to 3 times greater than women without hypertensive disease of pregnancy. This difference persisted after adjustment for potential confounders. Most patients readmitted with heart failure were readmitted within 2 weeks of discharge after delivery. Women with a diagnosis of heart failure at readmission were readmitted sooner, had a longer length of hospital stay, and had substantially higher costs of readmission than did women without a diagnosis of heart failure. The authors conclude by underscoring the adverse cardiac effects of hypertensive disease of pregnancy that includes heart failure and the attendant need for readmission, and with duration of hospitalization being longer and being more costly. The third highlight is a clinical practice guideline entitled The International Society for the Study of Women's Sexual Health Process of Care for the Identification of Sexual Concerns and Problems in Women. This article is authored by Dr. Sharon Parrish from the Weill Cornell Medical College, New York, and colleagues from several national and international institutions. Sexual health concerns are common in women of all ages. When a sexual problem causes significant distress and impairment, this may be diagnosed as female sexual dysfunction. Despite their frequency and impact, female sexual dysfunction is often substantially undetected and unaddressed in primary care settings, and are commonly undertreated even when they are recognized. Distressing problems related to desire, arousal, and orgasm affect 12% of women across the lifespan. Low desire is the most common sexual problem, but sexual pain and other less common disorders of arousal and orgasm are also seen in clinical practice. Clinicians who do not specialize in sexual medicine may not feel comfortable detecting, managing, and referring women for sexual health concerns. Reasons for the failure to detect and treat female sexual dysfunction include deficits in specific knowledge and skills, such as those required to engage women in effective discussion about their sexual health, and awareness of the availability and efficacy of treatments. In response, the International Society for the Study of Women's Sexual Health convened a multidisciplinary international expert panel to develop a process of care which outlines recommendations for identification of sexual problems in women. These recommendations represent the consensus of experts on the competencies needed by clinicians who serve either as primary caregivers for women, for example, specialists in gynecology, family medicine, internal medicine, as well as any non-sexual medicine specialists in other fields. These recommendations are useful for clinicians with any level of competency in sexual medicine. This article begins with an overview of the epidemiology and scope of, the basis for, and the nomenclature employed in female sexual dysfunction. The process of care begins with the expectation of universal screening for sexual concerns and proceeds with a four-step model. This four-step model accommodates all levels of engagement and includes eliciting the story, naming, reframing attention to the problem, empathic witnessing of the patient's distress and problem's impact, and referral and/or assessment and treatment. The process of care also delineates a process for referral when patients' needs exceed the clinician's level of expertise or engagement. Screening is best initiated by a ubiquity statement that assures the patient that sexual concerns are common and can be revealed. Patient-centered communication skills facilitate and optimize the discussion. The goal of the process of care is to provide guidance to clinicians regarding screening, education, management, and referral for women with sexual problems. In summary, this consensus recommendation discusses the scope and nature of female sexual dysfunction and a process of care that delineates the skills and knowledge required to screen for sexual problems in women, to carry out the four-step model of care, and to develop treatment and management strategies that may include referral to specialists as is indicated. You can access these highlights and editor's choice articles free of charge during the entire month of May. When you visit our Mayo Clinic Proceeding website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who've made a strong impact in their field of study. Currently, we are featuring Dr. Carlo Brugnara, a professor of pathology from Boston Children's Hospital and Harvard Medical School, Boston, Massachusetts, interviewed by our associate editor, Dr. Vincent Rajkumar. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.